All right, well, welcome back to another audio lecture. This is going to be the last lecture of the cardiovascular chapter. In this lecture, we're going to be talking about a disorder that affects tissue perfusion and cardiac output, and that is shock. And so, shock is a reduction in blood pressure that results in a decrease in organ perfusion, right? And it can ultimately lead to a decrease in cardiac output if venous return drops so much that now preload drops and cardiac output can't be maintained. Right, so you have to maintain preload and venous return for cardiac output to be maintained, and for tissue perfusion, you have to be able to have enough of a driving force. So remember that was one of the components of blood flow was a pressure gradient, and if now you are essentially getting rid of that pressure gradient, you have a high pressure and immediately drops off the bottom, then you lose that pressure gradient, and so it no longer effectively perfuses organs. Right? So we see that shock is defined really as decreased organ perfusion. We have multiple types. We have distributive, which includes neutropenic, septic, and anaphylactic. And so neutropenic is going to be originated from the brain, neural sources. Septic is going to be a bacterial infection in the blood, and anaphylactic is going to be due to a hyperinflammatory or hypersensitivity response. The other mechanism, one of the other types we have here is cardiogenic, and so it originates from the heart, right? So maybe the heart stops working, stops being able to pump the blood and maintain perfusion of the actual organs, and then hypovolemic. So hypovolemic is a reduction in blood volume. So if you don't have the blood volume to maintain blood pressure and to maintain tissue perfusion, then you could end up going into shock. So oftentimes blood loss is the cause of this hypovolemia. So we have some various stages of shock, and at least if we look at the figure to the right here. And so the first stage really is going to be compensation. Okay, so we've seen this before, and so you get this decrease in blood pressure. Well, the body just tries to compensate for this, right? And so we go over here, we look at all the mechanisms. We saw the same thing in the heart, right? In the heart failure. In that heart failure, we were looking at compensatory mechanisms, and the compensatory mechanisms include the sympathetic nervous system. So the sympathetic nervous system causes all kinds of responses, right? So it drives up blood pressure by vasoconstricting and increasing heart rate, increasing contractility of the heart. Right? This can cause a thirst as well. This thirst can drive up blood pressure, and then we could get some anxiety occurring. Another mechanism could be the renin-angiotensin-aldosterone system, so the RAAS, and so angiotensin 2 is formed from the decreased perfusion of the kidneys, and so this angiotensin 2 that is formed induces vasoconstriction, which will drive up blood pressure in the intermediate time, but it isn't a good long-term mechanism. Really, the long-term mechanism here is trying to drive up blood volume, because there's a reason why we have shock if we can't directly fix the problem right away. Right? So this angiotensin 2 maintains blood pressure for a short time. It induces aldosterone release. Aldosterone causes sodium retention, and water follows sodium, so we're increasing blood volume indirectly. The last mechanism here is going to be antidiuretic hormone secretion. So antidiuretic hormone directly is responsible for retaining water, for increasing permeability in the collecting ducts. But again, all these mechanisms are just short term, right? So the compensatory mechanisms end up failing as well. And we see it progress, and so it gets worse, and so these compensatory mechanisms fail. Oxygen delivery to organs decreases. And so we see some of the direct effects of the decreased blood pressure, right? And so we switch to anaerobic metabolism. We aren't able to produce the ATP. If we aren't able to produce the ATP, with lethargy can could also be sorry. Lethargy could be interpreted as fatigue or inability to generate the action, weakness, and so um, if we don't have the ATP, then obviously we're going to lack the energy to be able to do things. Okay? Anytime you have anaerobic metabolism, and we'll talk about this more in the electrolyte and acid base chapter, which is chapter 6, um, we'll talk about it more there, but we actually start talking about metabolic acidosis, and so anytime you undergo anaerobic catabolism or metabolism, we take the risk of developing metabolic acidosis, and this is because our cells are now working without the presence of oxygen, and they are producing really an abundance of lactic acid, and then some other acids as well. We also can then progress into irreversible organ damage. So this is over here, and so when we start interrupting really blood flow to the organs, we try to vasodilate in response to that acidosis, and that really progresses this disorder. We don't really want to vasodilate anymore because our blood pressure is already low enough. We want to maintain that blood pressure at a constant level. So this vasodilation is really not a good thing, right? So it decreases venous return further. And it also has effects on the organs as well. And so it decreases blood flow to organs. So anytime we are sending blood to other directions, that is going to decrease flow even more to another direction. So it's going to slow the flow. We could get thrombi forming in circulation, which we already discussed in another audio lecture. We could get ischemia in organs because now the blood flow isn't adequate enough to meet the metabolic demands in the organs, right? And so we start to see function of those organs affected. Maybe they start to undergo necrosis, and so now your cells and tissues start to die. Okay. Ultimately, we have decreased venous return. If we get decreased venous return, preload decreases, cardiac output decreases, and really it gets even worse from there, right? And so we get severe acidosis. Now the central nervous system starts being affected, and the organ damage and organ failure starts to result. So kidneys are really one of the first things, and the lungs begin to fail as well. And then we start to see decompensation. Okay? So this is really a progressive disorder that we see here. So somebody's going in shock, you really want to target it right away and get it treated really while the compensatory mechanisms are still working, and so try to work with them and reduce the chances that the disorder carries on further. What are the manifestations of shock? They should all be manifestations that reflect a reduction in cardiac output. Thirst. Okay. So thirst is a sign that you need to drink more fluids and drive back up your blood pressure. Okay. Your blood volume, that increases your blood pressure. Tachycardia is the result of a reduction in cardiac output, right? So you're increasing the heart rate. This is one of the compensatory mechanisms and one of the effects of the sympathetic nervous system. It's tachycardia. We need to circulate, drive up blood pressure to maintain perfusion of organs. Tachypnea, because now we're fatigued, we're not transporting as much oxygen, we're suffering from tissue ischemia, and eventually if that ischemia gets prolonged, now we end up developing necrosis. Okay. Cool, pale skin, because tissue perfusion has decreased overall. So if you don't have adequate blood flow, the skin doesn't have its normal characteristics. Hypotension, anytime cardiac output decreases, hypotension is going to result. Um, and then as things get worse and worse, cyanosis. Okay. So cyanosis would be representative of a decreased perfusion of the lungs, right? So, and that's this is really not good. Yeah. And then this last case here, decreased diuresis. So this is going to directly impact kidneys, right? So anytime urine formation is dependent on blood flow and blood pressure, right? And if your hydrostatic pressure decreases, you decrease the ability to perfuse your kidneys. Okay? Compared to hypertension, where you get hyperperfusion, because now we get hyperfiltration because hydrostatic pressure is increased, and shock, the blood pressure isn't enough to really facilitate urine formation. How's it diagnosed? CBC, you're going to be looking for things that indicate inflammatory responses in the case of anaphylactic shock, even septic shock, right? So we would probably be looking for white blood cells. In that case, we might want to do a blood culture, right? So here we might be, if you have a bacterial infection of the blood, the white blood cells would indicate that if they are in high numbers, but the blood culture would also provide growth, right? So if you a blood culture is where you try to grow bacteria on a agar plate, and so if you culture the blood and you're able to grow some bacteria from that blood sample, that can be an indicator. We can see coagulative factors increase, right? And so remember that was one of the disorders, right? It's thrombi formation, because now the blood is becoming stagnant, it's stopping. Cardiac biomarkers, so troponin, other cardiac biomarkers that we're looking for cardiac damage or cardiac death. Okay. Imaging, you're going to be looking for blood flow through arteries. You might even do an arteriograph to look at blood flow. Blood gases, this would you be looking for oxygenation levels and carbon dioxide levels, and anything abnormal. So if the oxygen levels are low or carbon dioxide levels are high, maybe in your blood scan. So in this complete blood count, you're going to be also looking at the blood characteristics, so the pH of blood, and if that is low, your arterial blood gases are likely going to be low as well. Right? Your ECG may show abnormalities because now you're starving your cardiac tissue of oxygen, right? And so if you're starving that cardiac tissue of oxygen, the sodium potassium pumps can't pump normally, they can't act normally, they don't have the ATP to function properly, and so you can't restore membrane potential back to its original condition. All right, and so you don't really treat shock. You try to manage it and prevent it from getting worse, trying to restore conditions to their original status. And so one of the big things here is to maintain respiratory function. So this might mean that you put somebody on a ventilator to maintain the lung function temporarily. You might provide supplemental oxygen to make sure that you're delivering enough oxygen to the blood that is circulating through the lungs. Because remember that the lungs, one of the disorders was pulmonary perfusion, right? We are going to monitor cardiac function to make sure that the heart doesn't get worse, to make sure that the ECG stays consistent, that this is normal as possible. Right? In the case of hypovolemia, in probably all cases of shock, fluid replacement is going to drive up blood pressure in all cases. And so that is really the condition is setting the stage for the body to do its own work, right? So you try to maintain it in the temporary, and then you'll begin replacing or adding things in that help the body do its job. So this fluid replacement, you're going to deliver saline solution to try to get fluids back up to a normal level so that blood pressure can increase by increasing the blood volume. All right, so that's it for shock. Okay, I would really focus on shock, on really understanding this figure. I think is good. This describes how shock affects organs. What are the compensatory mechanisms that affect that shock induces, um, and so and of course, what is shock, right? So, all right. Well, until next time.